Assalamu alaikum. The long clinical consultation day. The first scenario, your role, the doctor in the medical assessment unit. The patient name, Mr. Adam, 34 years old, present with collapse. The chart, vital chart, blood pressure 120/80, pulse is 78, respiratory rate 22, oxygen saturation 98, 96. Please take history, examine the patient, and address his concern. You can start.
Okay.
Yes, you can
okay.
start. Here you go.
Okay. Okay. Good evening. I'm Dr. Musa, doctor in the medical unit today. Let me confirm you are Mr. Adam, 34 years old.
Yes, doctor.
Okay, Mr. Adam, brought to my knowledge that you have loss of consciousness. So could you tell me, please, about this condition?
Yes, doctor. Actually, doctor, it was like exhausting day to day. I was very tired in the work. Okay, then I went with my brother in the afternoon for a shopping in the mall. Then all of a sudden, I found myself here in the hospital.
Okay, Mr. Adam, what do you mean about fall? Do you lose your consciousness or just dizziness?
Actually, doctor, I was in the mall and I wasn't aware of anything. Then I woke up here in the hospital.
So you lose your consciousness. Okay, did you feel anything before this collapse, like any shortness of breath or any racing heart or any blurring vision?
No, doctor.
Is it what is the climate? Could you tell me the situation in the mall? Did it was hot or you exhaust yourself?
No, doctor. It was like regular. No any hotness there.
Did you feel any fogging of your vision before the collapse?
No, doctor, I did not.
Did you injure yourself during collapse? Any injury?
No, but I feel some aches in my body.
Okay. So your brother was in the mall, yes?
Yeah.
Did your father notice that the color of your face, it is blue or pale?
Yeah, he told me I was like pale, but
Did you bit your tongue or bit yourself?
yeah, doctor. Actually, it was embarrassing that I whipped myself.
You bit yourself?
I whipped myself, yeah.
You bit your tongue?
Yeah. No, doctor, no.
Okay. For how long you have collapsed? Do you know how much time?
No, I don't know, doctor.
Did you check your blood sugar or your blood pressure after the collapse?
So I came to the hospital directly.
So you don't check your blood pressure, your blood sugar. Okay. Okay. Do you have any long-standing disease? Should be aware.
No.
Okay. Do you have any previous admission in the hospital?
No, doctor.
Can I know what's your medication list?
No, I'm not taking any medication.
Did you take any over-the-counter or any illicit drugs? Sorry for that.
Actually, doctor, with my friends before I was taking these party drugs.
Okay, sorry for that, Mr. John. Mr. John, when was the last time?
Maybe like 6 months ago.
Did you take it by blood channel or by mouth?
No, only like sniffing.
Sorry? By?
Sniffing, inhaling.
Inhaling? Oh, okay. Okay. Mr. John, do you have any weakness in your body or previous weakness?
No, doctor.
Do you have any numbness in your body, your leg or your hand, or previous numbness? Okay. Do you have any history of loss of your balance, or now you have loss of balance?
No.
Any abnormal movement?
No.
Do you have any vision problem?
No, doctor.
Any hearing problem?
No.
Did you notice that your mouth is deviated to inside?
No.
Okay. Any history of headache? Do you have any history of headache?
No, but I feel some headache now.
Could you tell me the character of this headache? This is dull aching.
Yeah, it's like aching, yeah.
What is the how much you give this headache? 1 is minimum and 10 is maximum. So how much you give this pain?
It's like 3 or 4.
Okay. Which side exactly?
It's like all over my head.
Did you notice that the headache increased by coughing or sneezing or leaning forward?
No, I did not.
Okay. Okay, Mr. John, do you have any history of fever?
No, doctor.
Any neck stiffness?
No.
Did your symptoms notice that you have numbness when exposure to hot baths?
No, doctor.
Okay. Do you have any history of racing heart?
No.
Any chest pain?
No.
Do you have any history of leg swelling?
No.
Okay. Do you have any cough? History of cough?
No, doctor.
Cough of blood?
No.
Do you have any noisy chest?
No.
Okay. Do you have any do you have any increased body temperature?
No.
Any tiredness?
Before?
Before and now, yes. Now you have
Yes,
tiredness.
I feel tired now.
And before?
Before, no.
Okay. Do you have any weight changes?
No.
Any weather preference? You prefer hot weather or cold weather?
No, doctor.
Anyone notice that you are pale than before?
No.
Okay. Do you have any joint pain before?
No.
Any skin rash all
No.
over the body?
No, doctor.
Any back pain?
No.
Okay. Mr. John, can I ask you a private question if you don't mind?
Okay.
Okay. Are you married?
Yes, doctor.
Do you have any casual unprotected relationship?
No.
Sorry about that. Do you have any problem in your intimate relationship?
No, doctor.
Any history of travel recently?
No.
Okay. What do you do for a living?
Actually, doctor, I'm a teacher, but sometimes in the evening I'm doing like a part-time driver.
Okay.
Taxi driver.
How much these symptoms impact in your daily activity?
Nothing, doctor. It came like suddenly. Today it came like suddenly.
I'm really sorry for that, Mr. John. I would help you about that. Do you smoke, Mr. John?
Yes.
How many cigarettes and for how long?
It's not too much. It's like 5 to 6 cigarettes daily, maybe for 10 years now.
I advise you also to stop smoking, Mr. John, because it put a risk on your health. Do you drink alcohol?
Yes, doctor.
How much and how much unit per week?
Maybe 20, 25 units.
Did you drink alcohol when open your eye in the morning?
No, doctor, mostly in the evening, sometimes with the friends. Sometimes I binge drinking also.
Did you try to cut down the alcohol?
No, doctor.
Anyone annoyed? Did you feel anyone annoyed from drinking alcohol from your friends or your neighbors?
Yeah, sometimes my wife. Yeah.
I advise you, Mr. John, to stop alcohol because it put risk also on your condition and in your health general. Mr. John, do you drive?
Yes.
Okay, I need from you now to stop driving at the time being till we diagnose you. Okay. Okay, Mr. John, I will ask you some general question. I ask it to all my patients. Do you have any tummy pain?
No.
Any mouth sores?
No.
Any difficulty swallowing?
No, doctor.
Okay. Did you have any change in your bowel, like any loose motion or constipation?
No.
Any change in water work, like increased amount or any soreness, you feel pain in your water work?
No.
Okay, very good. Mr. John, can I know how much you drink coffee and tea per day?
No, it's not too much. Like maybe one time coffee, one time tea.
Okay. Do you have any family history of any brain disease or any stroke, early stroke?
No, but I have my cousin doctor. He has a disease. I think it's called epilepsy.
Mhm, mhm.
Yeah,
Okay.
it's my cousin.
Which age he have epilepsy?
Since he's young, he has his disease. Do you think I having the same disease, doctor?
Okay, I appreciate your concern, Mr. John. Till now, it is one of the possibility in my list. I need now to examine you, and I will refer you to brain doctor. He will put a plan of management to you. Okay,
Okay,
I want to examine you, please, if you don't mind.
okay,
Okay, first, I want to examine the gait of the patient. I ask from Mr. John to stand, please, and start walking.
okay,
Okay, do you
okay.
any change?
Yes, what do you expect or what do you want to check?
Okay, do you feel any dizziness in standing from sitting position, Mr. John?
No, no,
Okay, do you have any abnormality in your gait?
no.
Okay, I would like to do a Romberg test. And
Okay,
I put my hand between anterior and posterior to Mr. John,
yeah,
and ask you to close your eye
okay.
if it is positive or negative.
Negative.
Okay, please, Mr. John, can you sit in the bed?
Okay,
Okay, I will examine the hand for any first for any rash in the hand, and then I would
no,
like to do nose finger to nose test.
okay,
Okay, it is positive or negative?
no, nothing.
Nothing. Okay, I would like to
Mm,
do pronator drift.
okay, no
Uh,
pronator drift.
no pronator drift. Okay, then I will go to the eye. If there is any Mr. John, do you have any problem in the acuity of your eye?
No, doctor.
I will check. Okay, I will do H shape, and also I would H shape and the field by count the finger if there is any
Okay,
temporal hemianopia.
okay, nothing.
Okay, I would also check. I want to check the fundus of the
Okay,
patient.
no need,
Okay,
no need.
then I want Mr. John, can you smile for me, please?
Okay, normal.
Okay, then I will go down to the carotid if there is any carotid below or in case the GVP.
No,
Okay, then I will go to the heart if apex if there is any displaced apex.
no, it's normal.
Okay, sorry, I will check the pulse first, but now I will go to the lower limb to check the tone, the
The
tone,
tone,
yes, tone,
normal.
the power in
The
the
bu-
power, yes,
it's okay.
it's okay, and the
Mm.
reflex and the
What
plantar,
reflex?
yes,
Enter normal.
plantar,
Yeah, normal.
normal, okay, okay, Mr. John. Can I ask you at
2 minutes left.
yes before you have a collapse, you feel that you are hungry or you have or thirst?
No, doctor, but I was hungry, but I ate something before this. I went with my cousin to a restaurant and I ate something.
Mhm. Okay,
Mm.
I want to finish my examination by check blood sugar and the blood pressure sitting and standing. Yes, blood sugar and and temperature.
Yeah, blood sugar now is okay and the blood pressure is normal.
Okay. Okay, Mr. John, can I know what's your concern, please?
So what do I have, doctor, exactly?
Yes, Mr. John, after taking history and examination, I have many diagnoses for you. One of them may be epilepsy, and the cause of collapse may be after the fits. What we are going to do now, I will do some blood test and also some scanning to your brain, and I will refer you to the brain doctor. And after the result released, we will have another meeting to tell you the result. That I want from you now to stop driving at the time being, and also try to cut down alcohol intake and stop smoking.
For how long I stop driving, doctor?
Yes, first it will be I want from you to inform the DVLE, and they will update you, but at least it will be at least 6 months.
Okay.
Okay, Mr. John. Mr. John, do you have any rash in your abdomen or your back?
No, doctor.
Okay.
Okay, time is up. Questions? Examine a question, please, Dr. Alex.
Okay, can you present your case?
Yes, Mr. John present quiz complaint of collapse. He was in the mall with his brother. He have he have also he has bitten in her tongue and also with himself. During neuro examination, I couldn't appreciate any neurological any abnormal neurological finding. Also no carotid bruit. Also, I couldn't appreciate any cardiovascular abnormality. So, my first official diagnosis will be post-ictal fits, and my second official diagnosis will be vasovagal syncope.
So what's your first differential?
Epilepsy.
Epilepsy.
Yes.
Okay, any other?
Epilepsy and vasovagal syncope may be butcher hypotension vasovagal. Yes, maybe reflex syncope, but I didn't ask him if he see any bad any stress or anything. Maybe reflex syncope.
Okay, any other differential in such patient with collapse?
Yes, maybe hypoglycemia.
Sorry?
Hypoglycemia.
Okay. Any other?
No, Dr. Ali.
Okay, so what's your investigation?
Yes, my investigation, I will do basic blood test like CBC and CBC looking for any anemia, any increase of blood cells looking for any infection. Also, I would like to do inflammatory marker like CRP, ESR, and also sorry, and also electrolytes. For my official diagnosis, I would like to do CT scanning and also stroke survey like carotid duplex and ECG and echo, and CT to exclude any hemorrhage. Yes, maybe subdural hematoma. Yes. I would like to do CT and CT to look for any subdural hematoma, and carotid duplex, just that.
Any other thing?
Yes, I would like to do, if the patient has palpitation, I would to do Holter, but the patient doesn't have any palpitation. Also, tilt table test for vasovagal syncope. And also maybe we need EEG for epilepsy.
Okay, what's your management?
Yes, management, it will be by non-pharmacological patient-to-patient counseling. Patient may need to involve also occupational therapy,
Occupational therapy?
Yes, if patient doesn't have weakness, so I'm sorry. No occupational
Mm.
therapy. Okay, pharmacological by multidisciplinary team of nerve doctor, um, nerve doctor, and treatment according to the cause. If the patient is vasovagal syncope, if the patient has epilepsy, it would be the plan will be by neurologist. If the patient has subdural hematoma, I will refer the patient to neurosurgery. If the patient has vasovagal syncope, I will give him some precaution to protect him from any other attack in the future.
What the precaution you should tell the patient, such patients?
Precaution according to the cause. The patient is heavy alcoholic, and so I will ask the patient to try to cut down the alcohol and moderate his alcohol use because it may be trigger the epilepsy, and also vasovagal. If the patient has vasovagal syncope, I would advise him try to keep himself good hydrated. Try to not stand for a long time, and also must the patient when he stand from sitting position stand slowly.
Okay.
Mhm. So this patient, sorry, first patient diagnosed will be subdural hematoma, and
First,
yes, subdural hematoma,
of
and
course.
second epilepsy, and the third vasovagal syncope. Okay,
Okay.
thank you, Sarah.
Thank you.
Okay, time is up. Any more question, Dr. Ala?
No, Dr. Bassem, thank you.
Okay, I will ask him one question only. Do you think vasovagal attack patient will lose his conscious level for all this long time?
No, Dr. Beth, no, it will be short time, yes. Mhm.
Okay, okay, fair enough. Dr. Ala, your comment, then I will comment.
So, actually, this case, like a straightforward case, it's a case of seizure. And I knew that it's coming frequently in the exam. And the key for this case is the analysis of the collapse. Okay, so we should ask before, during, and after. Before the collapse, as Dr. Mahmoud asked, any heart racing, any hunger pain, but he asked lately about the hunger pain, any sweating, any abnormal taste or smell. Okay, this patient, he had abnormal smelling before the attack. Okay, during the attack, is there complete loss of consciousness? Did you feel like the room is spinning around you because of the vertigo? Any jerky movement? Okay, this patient also, his brother told him that he has jerky movement in his all limbs. Okay. After the attack, how it ends? Okay, anyway, it ends spontaneously and you regain full consciousness, or someone give you medicine. Okay, did you have any weakness in any parts of your body, any tiredness, any confusion, any dizziness? Okay, so the approach of such case, it's a straightforward case actually, like for seizure, but it depends on the analysis of the collapse. Okay. Dr. Mahmoud did ask about the jerk movement and also the aura of the epilepsy. The other thing, okay. I think this is only from the history. Other than this, he asked about everything, like to exclude other secondary causes of seizures, like neurological causes, meningitis, encephalitis, fever. He asked also about autoimmune disease like skin rash, joint pain, and also the constitutional symptoms. But I think he took also a bit detailed history. Okay, and the case was straightforward with some additives like the alcohol intake. okay, and also the history of illicit drug use, okay, and the driving. Okay, the patient here was taxi driver, okay. So the advice here, I think, to stop like for 10 years, because I think we are dealing him like the category 2 drivers. The differential diagnosis, if you did the approach like this, you will reach the diagnosis directly that this patient had seizures. So we should know what's the cause of seizure. It's like epilepsy. He has family history in his cousin with epilepsy, or this is like secondary seizure to the illicit drug, but he took the illicit drug 6 months back. He's taking alcohol also. You put the alcohol in your differential diagnosis. And then you put the differential diagnosis of sudden loss of consciousness, like cardiac causes, like arrhythmia, long QT syndrome, like Hocum, and also the vasovagal attack. You can put it at the last. And also autonomic neuropathy, I think we can put it. Then the management of epilepsy. The second thing also in this case, which is important, the safety nettings. Okay, when you diagnose a patient with seizure, you should give him advice about the safety nettings, like if he to ask him about the hobbies. If swimming, he should be monitored. The bathing, should take shower not in the bath, and also to avoid risky behaviors, and also dangerous machines like rotating machines. So actually, it was like straightforward case of seizure, but only the most important is approach, and I think some points only you need to stress on them. I think that's it.
Yes,
Okay.
differential diagnosis. Differential diagnosis.
This patient, the first differential diagnosis will be seizure. Okay, it will be seizure. Okay, not epilepsy. So the seizure may be caused by epilepsy or caused by alcohol. Okay. The other differential could be other causes of syncope or loss of consciousness, like cardiac causes. But you will put like the exclusive criteria that you excluded. Okay. Like cardiac causes, but the patient doesn't have any history of heart racing like this. Vasovagal attack, but the patient regained consciousness rapid. The talk time to regain conscious level, and there is history of uncontrolled water work, and there is also the vasovagal. Also, he can have jerky movement, but not like the epilepsy. But he can also has jerky movement. But he will regain the consciousness rapidly. He will be fully awake after also regaining the consciousness. Okay, so you will put your first differential, the seizure. Okay, and if it's like idiopathic or primary, like epilepsy, or there is a secondary cause, and then you put the other causes of syncope or sudden loss of consciousness. Okay.
Yes. Yeah. Thank you, Dr. Ala, for the case.
Okay. Thank you.
Well done, Dr. Mahmoud. But I'm against vasovagal in this differential, because the patient of vasovagal, he will have stress, and he will he will regain the consciousness, or even he will not lose the consciousness for a long time. So what we have to put in the differential here, the seizure, epilepsy, and the other cause of syncope, like cardiac or arrhythmia. And you can say against that, hypoglycemia as well, and against that. Otherwise, I don't think the vasovagal can match the differential. The history taking, okay, Dr. Mahmoud did the analysis well, but the question for the seizure, you didn't ask more, Dr. Mahmoud, the epilepsy, and any change of your face color. I think no, you asked yes about pallor, but in the epilepsy, suppose the lips will be blue, right?
Below cardiac, Dr. Bassam, I think.
No, even with the seizure, because he will not be breathing, right?
Yes.
The other questions for biting, Yeah, biting himself or biting his tongue and wetting himself. All this confirmed the diagnosis of epilepsy. As Dr. Ala said, it's straightforward for epilepsy, but you have to confirm and rule out the other cause of epilepsy or seizure. I don't think the alcohol here can fit. He said yes, there is binge drink. Sorry, not the alcohol, the subdural hematoma. Why you mentioned subdural hematoma?
Patient alcoholic and fall. So
He had fall?
yes, a fall has fits in the market.
Yes, but did he fall down? I didn't hear it.
Yes, he fall
No,
down.
no, no, no. He had collapse. He had loss of consciousness.
When you ask him,
No
did you
history
injure
of fall
yourself? He
before.
denied, I think,
Mm,
right?
Yeah, yeah.
mm, yes.
Again, it's also not matching with the differential in this scenario. Always remember the cause of syncope. The most common cause of syncope in PACEs: cardiac, arrhythmia, and aortic stenosis. For example, aortic stenosis or arrhythmia under the term of or umbrella of cardiac. The epilepsy in young patients, of course, if he has shakiness of hands, and the hypoglycemia. Particularly the patient with insulinoma, history of weight of gain or gain of weight, and repeated hypoglycemic attacks, or patient already known as diabetic and he's very tight control to his diabetes. And the last one, you can mention anemia, but anemia will not lose the conscious level, right? TIA, if you have comorbidity, TIA and stroke, you can put as differential, but not in this patient. He's young. He doesn't have any comorbidity. He doesn't have diabetes or atherosclerosis or risk of atherosclerosis like hypertension or dyslipidemia, hypothyroidism, or this possible cause for atherosclerosis. But you have to put it in any elderly patient with comorbidity. Okay, these are the most common cause of syncope in PACEs in elderly, but you in the young age, epilepsy will be the prior. Okay,
Mhm.
epilepsy can come in the elderly age as secondary epilepsy to stroke, for example. So patient will have a history of stroke, and now he will present with epilepsy, secondary epilepsy. Okay, as Dr. Ala mentioned before, during, and after, the key to diagnose the case, how to get the clue through all the situation and circumstances, how the patient lose his consciousness or how he faint, and you have to rule out trauma. Very important for the welfare. If he injure himself, you will consider something happened like the hematoma, as you mentioned. So you have to go straight away for the CT brain, even if he regain the consciousness. Whenever the patient fall down and he hurt his head, for example, you will do CT brain as a mandatory test, not to diagnose the patient only. Also, you can be sure that nothing happened or no harm happened after he fall. Okay. Of course, with the elderly, the cause will be different. As I mentioned, sometimes they can bring as pacemaker, patient with pacemaker, either dysfunction or anything else. Okay. Any
Yes,
any question,
yes,
Dr.
yes,
Mahmoud, Dr. Ala?
yes, Dr.
Yes.
Bassem. What is the cause of headache in this patient, Ale?
Post-ictal.
Post-ictal, yes, there is
Post-ictal?
Yeah.
Mhm.
He told you he just has headache now after the seizure.
It was a straightforward case, Ale.
Only
Yeah,
in the analysis. During
post-ictal
the
is,
analysis, if you ask it about the jerky movement, he will tell you, yes,
yeah,
my brother
shakiness
told
is
me
very
about the
important.
shaking
Yes.
jerky movement.
Okay.
Okay, this will be like also before abnormal taste, abnormal smell.
Okay.
Yeah, the
Okay,
aura.
only the analysis. Yeah, the
Yeah,
aura.
the aura, particularly in the young age. Okay, the weakness is very important to ask. Why, Dr. Mahmoud? To ask about the weakness, any weakness?
Yes, to exclude stroke in this patient.
Yes, even TIA.
Even TIA, stop.
Yeah, stroke if the weakness persists, or TIA if the weakness recovered.
Okay, Dr. Basim.
Okay. Any other question, Dr. Mahmoud?
Thank you, Dr. Basim. Thank you. Thank you, Sarah.
Okay. Here, I don't think you can investigate for health table or even the sync for the vasovagal itself.
Yes, it is mistake. It is
Yeah.
mistake.
Whenever the patient didn't lose the consciousness for a long time, you cannot say this is vasovagal. The vasovagal only seconds. And whenever his position improve or his position settled, if, for example, if he lie down, he will regain his consciousness, even maybe with the sitting position. So he will be standing for a long time or in hot weather. Whenever he sit down, the fainting or feeling dizzy will be improved or subside. Okay.
Okay, Dr. Basim.
Okay. Any other questions from Dr. Ala or Dr. Mahmoud? Anyone want to comment?
What do you think, Dr. Basim, about the driving here?
Yes, any patient with seizure, witness seizure, first attack, he should stop driving. As a taxi driver, yeah, I think yes, it's type 2. So it will be longer time. You can reallocate him and refer him to the occupational, as you mentioned, from the first attack. Okay.
Yeah, and alcohol. Dr. Mahmoud, you mentioned cutting down alcohol. What do you mean by cutting down alcohol?
Yeah, stop it totally.
Stop alcohol.
But I think in epilepsy also moderate alcohol, not stop alcohol.
I think
In
if no
epilepsy,
hurt, yeah.
in epilepsy moderate, not stop.
In basis wise, they don't prefer to stop alcohol totally for those patients. So you will moderate the intake because it doesn't have the direct effect on it. Okay.
I think the two situations only we are advising the patient to stop alcohol in cardiomyopathy, heart failure, and also liver failure.
Alcoholic liver disease.
Yeah, these are only the two situations we are advising to stop the alcohol.
And maybe also alcohol toxicity.
Yeah.
But
Yes,
anyway, the most important condition to stop totally is alcohol liver disease. Even sometimes non-alcoholic liver, they can ask to moderate intake, but direct alcoholic liver disease, so it's the main reason to stop and cut down the alcohol. Otherwise, they don't prefer to talk about alcohol as stopping, only moderate the intake and try not to take it as binge drinking. Okay, this is what the UK examiner like. Clear?
Clear, Dr. Basim.
Okay, any question on or comment from others? Anyone want to comment? Any question? Dr. Aisha comment, rule out secondary seizure or provoked seizure, brain injury, the stroke.
Dr. Basim here will be the first differential to the secondary because this is clearly
Okay,
seizure. So we
Dr.
can,
Aisha, yeah, can you please closer to the mic?
okay. I think the differential here will be the causes of secondary seizure. So it is clearly seizures by description. So we can't do differential for another situations because it is true seizures by description of the patient and the witness. So we will put the differential to it is epilepsy or secondary seizures, and in old age it is very rare to having epilepsy on old age. So I'll prefer to making the secondary seizures first, the causes of secondary seizure.
But here the complaint or the presentation was with the collapse.
They describe about the seizures. It is the same It is true seizures by description of the patient and witness and all the characters of seizures.
I'm not sure, but whenever you have collapse, so you have to give the differential cause of collapse, not the causes of seizure. We can hear from others as well. Anyone has comment about this? But I think if they present or they give you a presentation of collapse, so you can give differential of collapse. What the possible cause of collapse in young patient or in young age?
Yes, Dr. Basim, as this patient presents with collapse, first I have to analyze the collapse. What he mean by collapse? Is this just fainting attack like lightheadedness, blackout like that, or it is a true seizure? Yani the patient feel abnormal jerky movement, and I will do my differential according to the presentation. He said he present with collapse, so I make differential for all of these. I think like that. I have to exclude if there is any.
No,
It may
for the
be
differential,
50.
Dr. Nahla. Dr. Nahla.
Yeah, yeah.
For the differential, if the examiner asks you what's your differential diagnosis of the case, what you will give him? The causes of a
First,
seizure?
if he said like that, the patient present with collapse, first I have to analyze what he mean by collapse. Yeah. If he look like just fainting attack, this may be also like this vasovagal syncope. If he said there is abnormal jerky movement and biting of the tongue and uncontrol of water work and like that, and any injury, this is directly I will go to the track of seizure.
No,
Yes.
the examiner at the end or at the discussion will ask you, give me differential diagnosis. This is my question and Dr. Aisha question. So
Yes.
will you
So
give
for
the
differential, I will
differential?
give differential for all. Like this, this may be seizure, and this is maybe just hypoglycemia. This may be
Yeah,
another cause of syncope, like that. This is
yeah,
what
this
I
is
mean.
this is my opinion as well.
Yeah.
So
But in case of what Dr. Aisha said, if the patient from the first, he said for me he came by fits, I will
this
analyze
is
what is
another
the cause of it.
presentation. If the patient
Yeah,
present with
yeah.
fits, you have to give the causes and the possible cause of fits or seizure in such age. And according to the group age, you can give differential. That makes sense. Okay, but you cannot, this is my opinion again, you cannot say the all cause of seizure because the patient present with fainting. You have to give the other possible cause of fainting or collapse or syncope in such group of age. Agree, Dr. Aisha now?
Maybe according to the scenario, really, Dr. Basim.
Yeah, they
Just
can.
mention the other before.
Okay, if he
Before
asks you what,
mention, make down the list the other causes that is will remain for second or minute or should have another presentation.
yes, okay. Let me tell it in another way. If the patient presented with seizure and they told you the complaint is abnormal movement and shakiness, yeah, this is the time to specify and to talk about the causes of seizure. Okay, for example, in my exam, it was a case of syncope. And I found the patient is having arrhythmia and he was having aortic stenosis at the end. And they asked me about the differential diagnosis. I mentioned the TIA and stroke, and he asked me why. I told him because he is having comorbidity like diabetes, hypertension. He asked me what else. I told him it's aortic stenosis. This is the case. And I give him the clue and the evidence of the aortic stenosis, the murmur and the finding and so on. He asked me what else. I told him arrhythmia. He said why? I said because this patient might have ischemic heart disease because again he has ischemic heart disease. He asked me again what else. I mentioned to him posture hypotension due to the medication. He asked me what medication exactly you mean. I said ACE inhibitor. Patient was on ACE inhibitor just added last month, and he had the seizure after that, or he had the fainting after that. So the differential, of course, scale was full mark. What I mean, if the presentation was syncope, So talk about the syncope, whatever the reason. You can mention all the causes, you know, but you can say against that, and every reason you can roll it out by one question. You got it? It's easy to bring a case with seizure, and he will tell you, please give me differential.
I know what you mean, Dr. Bassem. Just I need also to be logic in the case. So if you put after directly after this is seizures, and after that you will put like aortic stenosis or hypoglycemia or something like that, and you will have something suspicious to that.
Okay,
And
what you want to say
the
regarding
most
the
dangerous
possible
you
cause?
should mention first. You need to exclude the
Okay.
secondary causes of seizures because this is
Oh,
most
what
urgent
you
and
will,
most
what you will
dangerous.
mention? Okay, Dr. Aisha, what you will mention as a cause of seizure? If you will
According
say,
to the age of my patient, so if
so
he
okay,
take
give
alcohol
me
too much
reason.
like this patient, I
Alcohol.
put the second it's alcohol withdrawal, and after that I'll see I need to exclude any brain lesion or tumor in this patient. And after that, I'll say like any infection, like maybe subacute meningitis or encephalitis that may present with only seizures or personality changes. Even if no positives in this, but it should still considered.
Okay, it's for open discussion. I'm not sure about mentioning the all causes in such age with such presentation. You can say meningitis. Why you mention meningitis if he has, for example, frequent attacks, right?
If frequent attacks, it is truly epilepsy, and maybe epilepsy is the first now, if it is recurrent attacks.
So why
But
I should
also
think
you will put
about
the secondary
meningitis?
causes also.
Why I will think about meningitis if there is no fever and if there is no neck stiffness?
There is some types of meningitis that will be subacute, like TB. Also, viral meningitis, there is some of them without any fever. If the patient has low immunity or anything, would have suspicious. I don't mean this all, but according to the history, you need to exclude some of them.
Okay.
Yeah, I think also Dr. Aisha is right. And this also in the approach of the case. The case is diagnosed firstly with, you got from the analysis that the patient had seizure. Okay. So you should know what's the cause of seizure. Is this epilepsy? Is there a secondary cause? As Dr. Aisha mentioned, there is CNS infection, there is specific lesion, there is head trauma, there is risk of ischemia, stroke. As this patient, alcohol, hypoglycemia. Also, Dr. Mahmoud asked about heat stroke. Okay. That's okay, but I mean also in the bottom we can put the differential diagnosis of sudden collapse. But as Dr. Aisha mentioned, we should put in the first the seizures, and is this like epilepsy or secondary to other cause? Then we put
and maybe also Dr. Bassem, in just one item, we will speak to the examiner like that. This is a seizure, these characters of seizure in this patient. It may be primary or secondary. Secondary, like maybe you will mention 2 or 3 causes, then you will move to the second differential of syncope. But just mention that you are aware you should exclude the secondary cause.
Okay, if you, for example, let's imagine this patient is having meningitis. Definitely you will have the alarming and semester of meningitis. For example, fever and night sweats, lymph nodes.
One of the
Yeah,
presentation
but
of meningitis is just a seizures, and this is known presentation of encephalitis
yeah,
more than meningitis, but it is also a presentation without fever, yes,
okay.
or
Do you think I agree?
not
But
noticed the fever, yeah.
patient will faint only and he will regain the consciousness, or he will be in coma?
No, it is just like attacks because they have some abnormal brain chemicals. Like attacks, like then hypoglycemia would be also seizures, and it would be already um, um,
No, I'm
even
talking about
normal after.
meningitis. If you want to mention meningitis, the patient
Yes,
with
he will
meningitis.
have like also some stiffness, some neurological deficits. Not this only. The personality, maybe personality changes only, maybe some
And he
abnormal
will not
movements.
presented with fainting. He will not be presented with fainting. He will present with coma
Seizure. Yeah.
or seizure. Yeah.
Mhm.
But our presentation here is fainting, so I cannot say meningitis. One of the possible cause I should rule out.
Because
This
you
is my
already take
point.
the history, Dr. Bassem, you already take the history, and from the history you make sure that it's a seizure.
Mhm.
He bite his tongue. He have witnessed that he having jerky movement. He having rolling eyes. So you have characters of seizures.
Okay,
So you
so
should
the
be have
examiner,
suspicious. Mhm.
the examiner can ask you what are the causes of seizure. You know.
Yes, he can ask, but I think as this, it can be in one item only, Dr. Bassem. You can say my first differential here, this is a seizure, maybe primary or secondary. Secondary,
But
like
yes, this is
alcohol or
this
only in
is
one
what.
item. Yes,
Yes,
and
I
then I
agree
will
for
second the
this, but
differential.
I
Yes.
cannot put all causes as a differential. This is what I want you to say.
No,
or
just
add.
I put in first
Okay,
sentence, then
I
I
agree
can
to
mention
mention it.
others. Yes, yes.
Yes, I agree to say that. So epilepsy, with all different causes of epilepsy, if he asks you what do you know about the cause, you can mention. But the main presentation and the main differential here for fainting, I should say hypoglycemic and the cardiac causes, and against that, and against that. For example, how come in such
Yes,
age,
yes,
arrhythmia if he has
yes.
palpitation?
Now we are in the same line.
Yeah,
Yes,
yeah,
yes,
okay. Okay, we are in the same page since before, but to present more in details or just concise, this is the problem. If you will be concise to the seizure and quickly giving some example of the causes of seizure, okay, but you will not talk about the all causes of seizure as a differential in this scenario. No, you have to talk about the possible cause of syncope.
But
Okay.
just put them your mind
Yeah, as
to
headline
exclude in
and
the
yeah,
history. Yes.
yeah, as headlines. And if he ask, give me more reasons, so you can give more reasons. By the
Yes.
way, you can ask the examiner what differential you want for the main complaint or for the diagnosis.
He will
Okay.
ask clearly the question because they
Okay.
ask clearly. He
I
will
think
set first what is present and what is your diagnosis. He will see. So what other causes of what he will say.
exactly. Yes,
Yes.
exactly. Yes. Okay, good discussion. Thank you, Dr. Aisha. Anyone want to comment about this point or about the first case? Collapse is very important scenario and presentation. It might come in every diet and every center. Be ready to have a case and how to approach during, before, and after. How to give the common is common. So, okay, diabetic patient. If you have diabetic patient, definitely the hypoglycemia will be prior in the differential, or you can say the autonomic neuropathy, as well as the complication of diabetes, atherosclerosis, TIA, stroke, or cardiac ischemic heart disease, arrhythmia. But epilepsy will be in the bottom. Why? Because the patient will not be presented with shakiness unless he has hypoglycemia. So the shakiness can be explained with the hypoglycemia, or can be explained by the hypoglycemia. But you cannot say this is epilepsy. Okay. Anyone has question before moving to the next scenario? Okay, Dr. Ala, can you post the scenario for Dr. Mahmoud or the opposite? Dr. Mahmoud
Yes,
post?
I opposite. Yes,
Yes, I see.
Mr. Sami, 55 years old, complain of forgetfulness. Take history from his son, Nader.
Okay, Dr. Ala, if you're ready, let's know. I will add one comment regarding the DVLA and seizure, epilepsy. So the epilepsy patient will be banned from second epileptic attack. But for the group 2, I think from the first epileptic attack. Because he has risk for himself and others. The duration will be different, of course. 5 years and 10 years in the non-provoked. And for the provoked will be 6 months and 1 year. For group 1 and group 2. You ready, Dr. Ala?
Okay, Dr. Basim.
Okay, here you go.
Hello, I'm Dr. Mitwali. I'm the medical doctor in the clinic today. Let me confirm you are Mr. Nader, son of Mr. Sami, 55 years old.
Yes, doctor, I am Nader.
Okay, we are here to discuss about your father condition. Is that okay?
Yes, doctor, sure.
Can you tell me more about his condition?
Yes, doctor, my father complained of decreased conscious level since 5 days. Since it started, it is worsening, and I think he couldn't remember me and couldn't identify many people.
Yeah, and this started only 5 days ago.
Yes, doctor, started since 5 days.
Before this, he was completely normal.
Yes, doctor.
Okay, so it came like gradually or suddenly?
I think, doctor, it is started gradually and worsening since 5 days. Yes.
Okay, and what do you mean by decreased conscious? It's like he's not aware by his surroundings, or like he cannot recognize the people, or he's not awake at all.
Boss, the three doctor. I think he doesn't recognize the people, and his conscious level, I think it decreased by time.
Okay,
Mhm.
okay. Does he have any does he have any history of long-standing disease before?
No, doctor, but he has previously treated with was having hepatitis C virus and takes medication for hepatitis C since 1 year.
Yeah,
Mhm.
since 1 year.
Yes,
And
doctor.
he's taking his medication regularly?
Yes, doctor.
Okay, what medication he's taking?
I don't know, doctor.
Okay. Apart from the hepatitis C, any other medical condition he's being treated from?
No, doctor. No.
Okay. Apart from the medication for the hepatitis C, any other medicine he's taking?
No, doctor.
Okay. Any other like over-the-counter medicine he started recently?
No, doctor.
Okay. Any herbal medicines?
No, no.
Okay. Does he have did he have any fever?
No, doctor. I don't think so.
Okay. Any sweat?
Sweet, no.
Okay. Did you notice any change in his body weight recently?
No, doctor, but I think decrease weight, yes. His weight
Okay.
is decreasing, yes.
Decreasing?
Decrease. Yeah,
Yeah.
Mm.
And do you know how much weight he lost?
I think, doctor, he couldn't eat since a long time. So,
Yeah,
yes. So I think he lost 3 kilos over 2 months.
over 2 months, and his appetite is low.
Yes, doctor, I think that is.
Okay. Did you notice any bumps or lumps in his body?
I don't know, doctor. I don't know.
Okay. Okay. Does he have any weakness in any part in his body?
I think, doctor, he has generalized weakness.
Okay.
Mhm.
Did you notice any abnormality in his speech?
No, doctor.
Okay. Did he was he complaining from any abnormality in his vision?
Vision, no.
Okay.
But he wear glasses, yes. He wear glasses.
Since when?
Since long time, since 20 years.
Okay. Did you notice any shaking of his hands?
I don't think so, doctor.
Okay. Did you notice any problem in his gait?
His gait, he can't move, doctor, since 5 days. Since 5 days he is in the bed. Can't move.
I'm sorry for this, Mr. Nader.
Thanks, doctor.
Yeah. Did you notice like he's becoming unbalanced recently?
I don't know, doctor, because he couldn't move from the bed.
Okay.
He can't stand from the
Before
bed.
this, I mean, before this,
No,
no
doctor,
any
no.
problem in balance,
Before,
no.
no, doctor, no.
Okay. Okay. Does he have any tummy pain?
Tummy pain, no, doctor.
Any tummy swelling?
Yes, doctor, I think it is swelling. There is swelling in his tummy.
Okay. Any loose motion?
No, doctor.
Okay. Any constipation or hard motion?
No, doctor, I don't think so.
Did you notice any yellowish discoloration of his eyeball?
Yes, doctor, I think it is yellowish.
Yeah, and since when?
I think since 1 month. Since 1 month, yes.
Okay. Does he have any blood in his back passage?
Blood, no, doctor.
Okay. Did he complain like his stool is becoming black, more black?
Yes, doctor. Yes, I think yes. All right.
Okay. And since when this started?
I think since 10 days.
Okay. Did he complaining of feeling sick or getting sick or throwing up?
No, doctor, I don't think so.
Any throwing up of blood before?
No, doctor.
Okay. Did he have any cough?
Cough, no.
Any shortness of breath?
No, doctor.
Okay. Any chest pain?
No.
Okay. Any heart racing he was complaining of?
No, doctor.
Okay. Did he have any joint pain?
Joint pain, no.
Any skin rash?
No, doctor. Yes, there is, I think, bluish discoloration in his skin.
Sorry?
Bluish discoloration.
Where is exactly?
I think in the hand and in the back.
Okay. And since when this started?
Since long time, doctor. Since 2 years, it appear and disappear.
Okay. Okay. Does he have any family history of such condition or long-standing disease?
No, doctor. No.
Okay. Can I ask you what he's doing for living?
Yes, doctor, he is a teacher.
Yeah, and how much his symptoms affect his job and the usual daily activity?
Yes, doctor, since 5 days he couldn't go to the work. Yes.
Yeah,
So
I'm
it
sorry for this,
affected
Mr.
him.
Nader. Yeah, I'm sorry for this,
Thanks.
Mr. Nader. I hope we can help you regarding this issue.
Thank you, doctor.
Does he smoke?
Yes, doctor.
How many cigarettes and for how long?
Yes, doctor, I think 10 cigarette for 30 years.
Okay. So, Mr. Nader, I know he's not awake now, but I advise you also, we can advise him later to stop smoking. Okay, and if you need help also, we can refer him to smoking cessation clinic, and we will discuss this issue with him when he is fully awake. Okay.
Okay, thanks, doctor.
He drinks alcohol.
Yes, doctor.
How much units per week?
Yes, doctor, I think 10 units per week.
Okay. He need also to stop alcohol, Mr. Nader. Also, we discussed this issue with him also.
Yes, doctor, thanks.
Okay, Mr. Nader. Mr. Nader, he drives?
Yes, doctor.
Okay. He need also to stop driving for the time being until we assess his condition, and then we'll give him further recommendation.
Yes,
Okay.
doctor,
Can I
thanks.
examine him?
Yes, doctor. Sure.
Okay. I will start by examining the hand. Okay, for pulmonary edema.
Okay. There is pulmonary edema.
The uterine contraction.
Yes, positive.
Okay. Clapping.
No.
Sorry, the patient is like obeying commands.
Little.
He's confused, huh?
Like, yes, like confused.
Yeah. Okay, but we can check for tremors. Can elevate his hands for tremors.
Tremors, okay.
We'll check for tremors. There is tremors.
Yes, flapping tremors positive.
Okay, then I'll check also the observation charts, any abnormality in his observation chart.
Blood pressure normal, pulse normal.
Okay. Temperature.
Temperature normal.
Okay, then I will check his eye for jaundice.
Yes, it's positive.
Pallor.
Positive.
Okay, I will check for temporal wasting, temporal muscle wasting.
Yes, no, doctor.
Okay, I will check his mouth I will check for oral ulcers.
No, doctor. No
I will
ulcer
check
in the
for
mouth.
I will check for fungal infection, candidiasis.
Yes, normal. No, doctor.
Okay, and also dentation, if there is poor dentation.
No, normal, doctor.
Okay, then I will check the lymph nodes. Okay.
Okay.
Anterocular, posterior-auricular, submental, submandibular, anterior cervical, posterior cervical, and also supraclavicular lymph nodes.
Okay.
Okay.
No lymph node.
Okay, and axillary also lymph nodes.
Axillary, no lymph node.
Okay, then I will check the abdomen. I will do superficial palpation.
Yes.
Okay.
Okay.
Okay, any tenderness?
No, but it is tended.
It's
Swelling in the
swelling. Okay. Okay, then I will do deep palpation. I will check for hepatomegaly.
No hepatomegaly.
No hepatomegaly. Okay. Then I will check for splenomegaly.
No splenomegaly.
Okay. Then I will do percussion. Okay. For shifting dullness.
Yes, it is positive.
Okay. Then I will do check the lower limb also for pitting edema.
Okay.
Okay. Then I will check the back of the chest. Okay. For air entry or abnormal breathing.
Okay, it is fine basal crepitation at the base.
Okay. Okay. You told me he doesn't have any cough, huh?
No, doctor.
Okay. So, Mr. Nader, can I know what's your concern?
Yes, doctor, what my father have?
I appreciate your concern, Mr. Nader. Actually, from our discussion today and my examination, your father must probably have a condition which is called hepatic encephalopathy. Don't mind about the medical term. This is like a disturbance in the brain function caused by increase in toxic products in his blood. This because of abnormal function of his liver. Mostly this is caused by his hepatitis C virus, together also with drinking alcohol. Okay.
Okay.
So what we are going to do, we need to admit him now to the hospital. Okay. Then we will start for him treatment directly for this condition. We will run also some blood tests and we will run some imaging. We'll do a gel scan of his tummy. And also we have a suspicion that he may have a growth in his liver. Okay, so we need also to do blood test and the scan to confirm this. So, do you have any other concern?
Yes, doctor, is it a stroke?
I appreciate your concern, Mr. Nader, but actually from our discussion today, stroke is not a possibility, but also we have to exclude it. We will do scan for his brain to exclude if there is any brain lesion, especially bleeding, because also the liver problem may affect his bleeding. May affect his clotting.
Okay, doctor, thank you very much.
Okay.
Thank you.
Okay, thank you.
Thanks.
Okay, the questions, examiner questions.
Okay, present your case and tell me your differential diagnosis.
So this gentleman has presented with the decreased level of consciousness, which started gradually and was increasing over the last 5 days. He has baseline history of hepatitis C virus infection, and he was on medical treatment, and he is also drinking alcohol. On examination, he had positive findings of chronic liver disease in the form of pulmonary edema, jaundice. He has also findings of decompensated liver disease, like jaundice and also ascites, and also he has flapping tremors. In the examination, I could appreciate hepatomegaly, but this may be because of liver cirrhosis. So my first differential would be hepatic encephalopathy on top of decompensated liver disease. My second differential would be subdural hemorrhage. Okay.
Okay. Very good.
Especially with this liver impairment, and he has also ecchymosis, and also was drinking alcohol.
Okay. What else, doctor?
The other differential can be other causes of metabolic encephalopathy, like electrolyte disturbance.
Yes.
Okay, hyponatremia or hypernatremia. Or hypercalcemia. Okay, could be
okay.
could be
what else?
Yes, could be dehydration, but against this there is no any history of diarrhea.
Did you check?
Yeah, I asked him his motions. He told me no.
No check signs of dehydration?
No, I did not check.
Okay, doctor. What else?
Okay, could be uremic, could be uremic encephalopathy.
Okay. Did you check? Did you check
the water work?
Yes.
No,
patient has soreness in his water work.
Yeah.
Okay. Okay, doctor. Okay, the patient concern, the patient relative is stroke. So what is the GCS of this patient?
Actually, I didn't assess the GCS of the patient.
Okay. Did you find any lateralization because the patient doesn't have a stroke?
No, I didn't also assess the neurology. Also only flapping tremors.
Okay. What if the patient has hypoglycemia? Do you check blood sugar?
No.
Okay. Okay,
Punishment.
Okay.
You are right.
Okay, patient come with confusion. Did you check any neurological examination?
Yeah, should have been done, yes.
Okay. So what is the investigation to this patient?
So we'll do basic blood test. We'll do CBC. Okay, check for any leukocytosis. Okay, we'll do CRP. Okay, we'll do liver function test. We'll do kidney function test. We will do electrolytes, okay, like sodium, especially sodium. We can do also potassium. Okay, we
what you expect the electrolyte in this patient?
So this patient, I don't have any clue to any electrolyte disturbance, but maybe he had delusional hyponatremia because of the volume overload.
Okay, Dr. Ali. Okay, Dr. Ali.
Okay, we'll check also serum ammonia.
Yes.
Ammonia level. Okay, and this patient, we need also to do CT plate to exclude intracranial cause. Okay, we'll do ultrasound. Okay, for the abdomen. We need to do also alpha fetoprotein.
Yes.
Okay. We need also to maybe he need also triphasic CT abdomen. And for the
Yes.
ascites, we need to take acetic tab. Okay, for to check for the chemistry and cytology, and also to do culture sensitivity.
Sorry, again, Dr. Anna, again, please.
Acetic tab, we'll do acetic tab.
Okay.
I will take
Okay.
ascites for chemistry and cytology and also culture sensitivity.
Okay.
To exclude the spontaneous bacterial peritonitis.
Okay. What
I think
else?
that's it. Coagulation profile, of course.
Yeah.
I think that's it.
Okay, and the blood sugar.
The blood sugar.
Yes. Okay. Did you check? Did you apply digital rectal examination to this patient? To the patient has melena?
No.
Okay. Okay, Dr. Alaa, thank you very much.
Okay, well done. Thank you,
Okay.
Dr. Mahmoud, for
Okay.
you being tough examiner.
Yes. No, Dr. Alaa is my friend.
Yes,
Best
I know,
friend.
but he asked
But
you about conscious level. You told him yes, he's confused.
yes,
Then
confused.
yeah,
Really, Dr.
then you
Bassem,
ask him
this
what the
case,
GCS. Okay,
yes,
continue.
this case came last diet in Maadi to my friend. He asked him the same question. What is the GCS of this patient? Did you assess the GCS? Patient come with confusion. So with confusion, we have to do a neurological examination plus abdominal examination. He did the same, Dr. Alaa, and he lost the station. Lost the clinical judgment because he didn't ask about GCS, and lost physical science, don't do neurological examination, and didn't acquire blood sugar. So I come this case to Dr. Alaa to pay attention also to him. This case came a lot in Egypt. Patient came with confusion. So it is started since 5 days. Patient has previous history of hepatitis C virus. Dr. Alaa asked me about any history of bleeding. It is a good question. And the patient has tiredness, and also a patient cause of hepatic encephalopathy. Patient has soreness in his water work. So he lost also communication. Differential diagnosis to this patient, Dr. Alaa do it well. First, hepatic encephalopathy. Second, electrolyte imbalance. Third, subdural hematoma. Fourth, UTI. Okay. Examination, I will come to the patient and see and assess the GCS. Roughly the GCS, because the examiner will ask you what is the patient confused really, was confused. Patient has hepatic encephalopathy really. So we have to assess GCS and to do at least the blunter and pupil and pronoted drift to know if the patient has a stroke or no. Because the patient, the relative concern is my father has a stroke or no. So we have to answer the concern. And so the neurological examination and all abdominal examination, even ballotment of the kidney and ascites. And also ask for the blood coagulation profile like BT and the BTT and the INR and the albumin, and measure of blood sugar. This is the most important because hepatic encephalopathy may have hypoglycemia. And any one of us will forget it was digital rectal examination because the patient has melena. I finished now.
Thank you, Dr. Mahmoud. Always
Thank
your
you.
comment is valuable. And you give us a real exam scenario.
Yes, it is a real
with the
exam, Dr. Alaa,
comments.
really.
Yes,
In the
this
feedback, I see the feedback of my friend. He write that GCS and the blood sugar in the clinical judgment.
yeah.
How he will do
So-
all this? He brings this case to fail the people. Only this.
Yes,
How
it
he
is
will do the all abdominal examination and neurological examination?
No,
How in one
neurological,
case?
just the pupil and the pronator.
Yes, but he need to do also the
Yes,
GCS. Yes, how?
because Dr. Aisha, it is a very easy case. Patient has past history of hepatitis C. Patient was jaundice and hepatic. So from
Yes,
start,
you will
from you
exclude
enter,
also in the history all causes of other causes of confusion. You should
yes,
ask about everything to exclude in old age. There is
yes,
many
but
causes of confusion.
you know this case for examination. If you do well examination, you will
And
not
for
lose.
history also, it will take time for history and take time for examination.
What
So
is
I think
what
no
is
one will pass
I
it.
say I think no history in this case. What is the history?
That's
No,
why.
a lot of history. You should exclude all causes of confusion. Any gastroenteritis, any bleeding, any vomiting of blood, any UTI, as you mentioned, any pneumonia. All
Yes,
these
it is.
causes of confusion in old age.
It is a challenging case.
Yes, they bring such these cases in
Yes.
عادي, especially.
Yes,
I
you know,
agree.
Yeah.
Dr. Aisha, all the corridor, all the 5 doctors lost the exam.
Yes, they
All the
also in
5.
my yes in my exam, one neurological case, the patient can't hear, lost hearing and not wearing any hearing aids. Neurological case, the only case in short exam you should coordinate with the patient all the station, and the patient can't hear you. And they said in the first instance, they will say to you, please raise your voice, the patient can't hear. Why you bring the patient can't hear in neurological? You can hear it in cardiology, in chest, because there is no not a lot of talk. But in neurology, you should, the patient should listen to you and you should listen to him. And also we are all the 5, we filled the station. And they write a note in feedback, the patient can't hear the doctors. But what about us? They bring like this case to fill the people on.
How to read a deaf patient?
Yes, he can't hear me, and he always making his head like that. So you don't know what is it is right or no, or so you will raise sometime your voice, and you will go to his ears to raise your voice. This is not an exam, something of mystery, or you should judge on me on my skills, not to having something you can't do. Even if you are the examiner and I ask you to do this case, you can't finish it.
You know, Dr. Aisha, even the UK centers, little tough, but there is no miss like this, really.
They always said to us, the station should be this. It will guide you towards the diagnosis. But if they making like that, you really
Yeah,
want to fail all the
sometimes,
people.
yeah, intentionally they do that. Particularly some centers, toxic centers, and all of them are known. Anyway, that's why I want to say Dr. Mahmoud today was tough examiner because he bring the same questions of the examiners.
Yes,
But
it is the same question.
yes, I
Dr.
know,
Abbas.
I know, I know,
Really,
I
the
know.
same
I agree
question.
with Dr. Aisha. You cannot do all this examination. You cannot take all this history. You have a chronic chronic liver disease patient, so you have to diagnose the cause with the manifestation of secondary or chronic liver disease, and to know what the original cause, alcoholic or hepatitis C or non-alcoholic. And in the examination, you'll examine for the manifestation of chronic liver disease. That's it. Don't ask me, did you do the GCS? So what if I do the GCS? I will intubate the patient? Will I do the mini mental state, for example? What the benefit? Patient is confused. Okay.
But I think here the GCS, we will just ask, or we need to examine GCS.
I don't know, Jala, really. But
I think we just ask.
that
We'll just ask for GCS.
3 items of GCS to determine the exact way.
We'll talk to the patient. We'll do painful stimulation for the patient. I think no. Only we'll ask for the GCS.
Yes, but it will take time to do the GCS.
Yeah, but here strong differential is subdural hemorrhage.
Yes, hepatic
Okay.
encephalopathy and
Yeah,
fluid imbalance,
this is the strong.
hyponatremia.
This is a strong differential. The second
Yes.
differential in this case, subdural hemorrhage. So as Dr. Mahmoud said, we should exclude any neurological deficit, at least with rapid neurological examination, only pronator drift and plantar reflex.
Yes, we should rule the TIA or the central cause. I agree with this. Pronator drift, plantar. But for the GCS, I can ask the patient if he's oriented to the person, to the time, to the place. But all GCS examination, even if I will miss it, he will not give me this minus in the marks. This is my point. Okay, you can minus me, but don't minus me to the level of fail or to the extent of fail, right? This is my opinion. Anyway, the case was drive well with Dr. Ala. He did really well, and he gave good differential. By the way, thrombocytopenic patient or any chronic liver disease, mainly or mostly, he are or they are thrombocytopenic. So you will have or he will have any bleeding, any type of bleeding. Okay, digital rectal examination you have to offer. I wrote some examination you have to offer, Dr. Ala, by the way. The parotid for the chronic liver disease due to alcohol, a scanty axillary hair, and gynecomastia. It's one of the important manifestation you have to examine. In the chest, from the front and the back, you have to examine for the spider nevi, as well as for the caput medusa around the umbilicus and the direction of the blood flow away of the umbilicus in case of portal hypertension. I guess this patient will have splenomegaly, not palpable spleen, sorry. Shrunken liver, yes, I agree. Unless he has the mass or hepatocellular carcinoma, so he might have palpable liver. Again, it's a straightforward case, but you have to address the all complication, the association, the underlying cause, the alcohol, particularly here. He should stop alcohol. Otherwise, if he has any sinister signs or constitution symptoms, you have to think about hepatocellular carcinoma, and the liver will be palpable mainly or possibly. Okay.
Okay, Dr.
Uh,
Bass.
yeah. Any question, Dr. Ala, you want to ask? Or you have any doubt about this case? Apart from the GCS, let's learn the lesson. If you have any patient confused, don't only ask for the orientation. You can even do the GCS. I don't think it will make difference in the judgment here, because GCS always used to either to give decision of intubation. But orientation, you can say a patient is not oriented. That's it. For the paces wise, I mean purpose. But anyway, some examiners, they are tough in mind. So you have to be ready to train how to assess the GCS quickly. Briefly, so the I, it's a GCS contain what? E, V, and M. E for eye opening. Yes. You want to
Dr.
mention it?
I'm ICU specialist. It's like easy for me to assess.
Yes,
But
I know. By the
yeah,
way, I am
but the
ICU
problem
guy.
that it is contains painful stimulation. You
Yes,
will
I
have to
know.
do painful stimulation for the
I
rest.
agree, Dr. Ala. I
Yeah,
agree with you. I am ICU also. I know how to do it
yeah,
in 2 minutes or
yeah,
less than 1 minute.
yeah,
Me and
yeah,
you. But let's
yeah.
teach others, because you might or they might face it in the exam.
You know, Dr. Bassem, sorry for 1 second. The
Okay.
patient in the exam wasn't on in hepatic encephalopathy. Patient was fully conscious, but he imagine himself as confused, like that. But the patient was conscious, but he يعني بيمثل ان
Yes,
هو
how he will
عنده
act like he has low
yes
GCS. How he will act
yes
it.
he
Because
will
he's
act.
also he's not educated.
Mhm.
He will answer you definitely because he's a surrogate. How you can assess the GCS based on conscious patient or a non-educated patient, because this patient is not real patient. Unless the examiner will tell you, yes, he's talking verbally well, and he's saying sounds, or he's saying only verbal words. So again, it doesn't make sense to ask for GCS and the examiner will give you the answer. It's not real patient to do GCS on him.
Maybe
For
they
me,
want to ask you only to mention that I
to
need to
offer it,
check.
okay, maybe yes,
Okay.
I agree,
But
yes.
if you said like that, they will say to check it. The
But
patient.
at least -1 mark, but not to fail all candidates.
Yeah.
Anyway, again, the trigger and the precipitating factor for encephalopathy you have to know: upper GI bleeding, or spontaneous peritonitis, or infection anywhere, hyperammonemia. you have to know the all possible cause for hepatic encephalopathy trigger. Okay, and you have to know the child scale or score, and the other score, I think mild score also, but I think mild for the acute paracetamol toxicity, right? For lung, for liver
Mild in
transplant.
alcohol only, I think. Mild in
Yeah,
alcohol.
for the lung transplant.
Mm.
Okay. Anyone with question? Dr. Ala, Dr. Mahmoud?
Thank you, Dr. Basim. But in this case, exactly, the examiner was very sad about my friend. Don't tell him about high blood sugar. So
Hypoglycemia,
yes, he was very angry. He told me, يعني aggressive with me. Why not check? Why you didn't check blood sugar? That is main
Yeah,
point.
it's common complication, and you should be aware about it. Any hepatic encephalopathy patient or chronic liver disease patient,
Yes.
possibly he will be hypoglycemic, or easily he will be hypoglycemic because of the metabolism of glucose in the liver is impaired. So most of them, they will have hypoglycemia. Okay, we as usual, we all of us learning from the mistakes of others or mistakes of ourselves, and we should be ready to face such cases. Any question, Dr. Ala?
No, thank you, Dr. Basim. Thank you, Mahmoud. It's a nice case, interesting case.
Thank you, Salah.
Any other question from others? Okay. Again, as general advice, whenever you have timely managed or managed your time, shortly manage your time, and you don't have enough time to do all steps of examination, please at the end tell him I would like to complete my examination by doing 1, 2, 3. Why? Because it can give you the mark even without doing this examination. For example, this GCS or digital rectal examination, because you will not proceed with the digital rectal examination. The examiner will tell you don't do it, of course, for the welfare, but you have to offer it, and he will give you good mark when you offer it. Okay, be smart and clever how to gain marks from tough examiner, even without doing the steps of examination. If I have time, I would like to do 1, 2, 3. If I have time, or I would like to complete my examination by doing 1, 2, 3. Okay, any question, Dr. Aisha, or comment?
No, thank you.
Anyone
Dr.
with
Basim,
comments?
But it is interesting case, and it can come really even
Yes.
in benign
And
centers or in benign way. Just we will do our best, and they will give you, even if you forgot 1 or 2 steps, they will give you the marks, because Dr. Ala really did well. So he
yes,
maybe missed some marks, but he will not fail the station if he did like this way, I think.
yes, and good center, yes, and benign center, yes. Yeah.
Or good examiner. إن شاء الله ربنا يرزقنا بيهم يعني.
Yes, I agree. Doctor, someone iPhone to assess the degree of encephalopathy. Yes, you need to assess cause of this decompensation, of course, degree of decompensation, to have good management plan. Yes, okay. Thank you, Dr. Nadia. Any other questions before ending the session? Anyone with question? Okay, if no more question, we see you tomorrow, inshallah, with communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.